Hi everybody, and welcome back to the Clean Scalpel. Today we're going to take a little bit different approach to what we've been doing before. In the past, we've focused on really working on our technical abilities, and this time I think we're going to also focus a little bit on sharpening the mind. So for the longest time, I've had a keen interest in vascular ultrasound, and over the course of the last few years, I've noticed certain topics that the students and residents have some difficulty with. And so for that reason, I've created a lecture course about peripheral physiology and its ultrasound findings. And so that's what we're going to review today. Okay, so without further ado, let's talk about peripheral physiology. So first of all, let's just go through what peripheral physiology is. And if you're in any way, shape, or form doing any kind of vascular surgery, you're going to see something like this. This is a segmental blood pressure, and you'll see the ABIs. And so let's just talk about this particular waveform. Okay, so let's blow that up. And what does this Doppler waveform represent? We'll make it very simple. Is this a normal waveform? Is this a normal hyperemic waveform? Is this an abnormal waveform which represents inflow stenosis, or is it an abnormal waveform with a distal fistula? Now I'll give you a second to think about it. And most of everyone here knows that this is indeed a normal waveform. But what we're going to focus on specifically is what really makes this a normal waveform. So we're going to, at this point, acquire the tools that are going to help us interpret the rest of this session, okay? So let's break this waveform down. First and foremost, there is a systolic upstroke, which represents initial forward moving blood. Now, the blood, as it's moving forward rapidly, decelerates. And so you have a rapid deceleration with early diastolic flow reversal. So the blood is actually going to slow down and then going to move backwards. And this is purely because of the high peripheral vascular resistance and a negative pressure gradient, which you normally see in the periphery. Now, once you get the rapid deceleration, you do then see the diastolic forward flow. And this is really a result of decreased peripheral vascular resistance, which then causes the blood to move forward. And most of you have looked at this and says, yes, that looks normal because it's a triphasic waveform. And hopefully I'm going to start getting you to move away from those terms, because what you may find is that even a biphasic waveform is a very normal waveform in certain pathologies. And we'll understand that as we move a little bit forward. What you have right here is really the anatomy of this particular waveform. So let's move on. What does this Doppler waveform represent? Now look at it carefully. It's in the right common femoral artery. And let's break it down like we did before, okay? But first, what does it represent to you? Is it a normal waveform? Is it a normal hyperemic waveform? Is it an abnormal waveform which represents some distal disease? Or an abnormal waveform and has a distal fistula? So take a second to think about it. And this one's a little bit tricky, but I wanted to get the point across that this can represent both a normal hyperemic waveform or an abnormal waveform with distal disease. And really the clinical situation would dictate the answer. So let's break down this waveform, okay? So the systolic upstroke is still sharp and represents, again, initial forward moving blood flow. And you know that that's a normal finding. Something interesting happens on this portion of it. You do get a deceleration, but there is no reversal of flow. And what this likely represents is lower peripheral vascular resistance and vasodilations. And the question you have to ask yourself after you look at a waveform is, why would there be lower peripheral vascular resistance and or vasodilatation? And what you find is that you can get flow-reducing arterial disease, which is more than 60% diameter reducing, or exercise-induced vasodilatation, both of which decreases peripheral vascular resistance and increases vasodilatation. So now that we understand that, you can see this very clearly as you look at these two clinical waveforms. The first one represents a normal triphasic femoral waveform, and this individual actually has a distal SFA stenosis, and you notice that this waveform is normal, but it is a response to the distal stenosis. Now, adding a little bit more complexity to it. So what does this Doppler waveform represent? Now look at it carefully. Is it a normal waveform? Is it a normal hyperemic waveform? Is it an abnormal waveform representing distal disease? Or is it an abnormal waveform representing inflow disease? So take a look at it. Think about how it differs from the previous waveforms we've seen. And if you pick it's an abnormal waveform with inflow disease, then you're 100% correct. So again, let's break that waveform down. What do you notice about the upstroke? Well, it's delayed, and this represents an increased time to peak as well as in lower amplitude. What about the deceleration? Well, the deceleration is definitely not as sharp as a normal waveform, and it does not have flow reversal, which represents decreased peripheral vascular resistance. Okay, and so this is compensatory for what's going on. And it's likely because of an inflow stenosis. The distal vessels have had to undergo vasodilatation to allow continued flow down the leg. And you can see an example of this. Again, the waveform you mentioned before. You have the patient with the distal disease, and then you have the waveform with inflow stenosis. Now, in this representation, the upstroke does look sharp and rapid, but these are in two different scales, and this is why it's so important to look at the scaling, and you see the peak of systolic velocity is really only about 37. Okay? Great, so we've really tackled a normal waveform, and this is, as you know, is just the beginning. So what about that funny looking number that you always hear, the arterial brachial index? Now, I love giving this question, especially to medical students and interns, because I can usually stump them, but those of you that are really have mastered this will make it easy. So let's, very simply, what is an ankle brachial index in this particular individual? Now this individual has a blood pressure of 75 millimeters of mercury on the right arm, 100 on the left, 100 at the dorsalis pedis on the right, and 75 on the left. And at the posterior tibia, he's got 75 on the right and 100 on the left. So take a second to think about it. And this is really kind of tricky for those of you that don't know, but this is a very simple test that I found to be able to help people understand what an ankle brachial index is. And if you picked or guessed D, you are 100% correct. And remember, you have to use the higher blood pressure of not only at the ankle, but also of the brachial, okay? So that's a very important thing. Most people will make the mistake of using 75 for the right side and 100 for the left side. No, it's always the higher, because again, we're always trying to look at perfusion. And this is why we look at an ankle brachial index. So let's go a little bit further into this. And again, the absolute values that determine this are the pressures. So you see the brachial pressure in the right and left arm. So again, you use the left arm pressure here. And on the right side, you would again use the higher of the dorsalis pedis or the PT. Okay? Now, when you're evaluating lower extremity pressure recordings, which finding is normal? Okay? Do you get a decrease in pressure from the thigh to the leg? Do you get an increase in pressure from the thigh to the leg? Is there an elevated pressure on the side with significant disease? Or is there an increase in pressure readings if the cuff size is increased? So think about that for a little bit. Think about the ones that you know are obviously incorrect. And if you picked number 2, then you are 100% correct. That is a normal finding. And why is that? Well, there is change in vascular compliance, which leads to increase in resistance due to muscular tone and the decreasing size of peripheral vessels. Now, is this relationship true for the upper extremity? Let's look. Okay, so as you glance across this picture, what you will find is a very similar finding because of all the reasons mentioned before. There is decreased size of the vessels and increased compliance, and therefore you will also get an increase in blood pressure as you transition from the upper arm to the forearm. Now, looking carefully at this as we transition to more concepts, where is the lesion on the patient's right side? Okay, so look carefully. I'll give you a second. Look at the right subclavian waveform, and you have the normal side here on the left. You have the axillary artery, brachial, radial, and ulnar. And here's a little multiple choice for the people that want to see it. Is it proximal to the subclavian artery? Is it distal to the subclavian artery? Is it mid-brachial artery? Or is it at the brachial bifurcation? Okay. And for those of you who picked distal to the subclavian artery, that is in fact the correct answer. Now, you're going to look at this and say, Dr. Shukla, that doesn't make sense. You don't really have a triphasic waveform at the right subclavian artery. How can you really figure that out? And you have to remember to look at the waveforms. Now, the waveforms are all sharp here. And remember, this is considered a normal waveform in the setting of stenosis distal to this location. Why? Because you don't have a reversal of flow, which again represents decreased peripheral vascular resistance. And this is something I really want to get people honed in on, because quite often someone will listen to this and they'll say, oh, it's a biphasic waveform. There must be something proximal to this lesion. But in fact, as you can kind of see, it is a normal finding in a patient with this disease pathology. Okay. The other factors that you have to look at is the change in amplitude. Okay. Clearly much smaller. And then you notice there's a significant change in amplitude as you get further down. Now, could you say it's the mid-brachial artery or the brachial bifurcation exactly? No, and that's a little bit of the test-taking skills as you undergo these exams. Well, let's shift gears a little bit and look at this particular study. Now, it's a PVR study, and for those of you who believe that stands for peripheral vascular resistance, in physiology class you'd be correct. But what it represents in vascular physiology is pulse volume recording. And just like we broke it down with the Doppler waveforms, we're going to break this waveform down. The way you obtain it is really putting blood pressure cuffs along different segments of the legs. And what this measures is the change in volume. Okay, so you're going to have to think about that a little differently. It's a change in volume as you undergo the cardiac cycle. All right, so with that in place, is this a normal study? My favorite question. So take a look at it. And if you don't know, that's okay. We will get to that. So to help you answer that question, let's break down this waveform, okay? So unlike what we learned before about Doppler waveforms, you're going to have to scratch that and think about this waveform quite differently. Now, you have a systolic peak, which again represents an increase in volume with systole. We're not talking about forward-moving blood flow, backward-moving blood flow. We're talking about an increase in the volume, which is what it measures, okay? So in systole, the volume in that segment increases. Now, you get a reflected wave, a dichrotic notch, which represents an elevated peripheral resistance. So in systole, the volume increases, it hits a peak, and then that volume decreases. As it decreases, the elevated peripheral vascular resistance does cause a dichrotic notch, okay? And then finally, in diastole, you have a gradual runoff. So the volume then decreases back to a baseline. So with this in mind, okay, again, it's a different concept. Let's go on to looking at these waveforms. So what does the increase in amplitude at the below knee segment represent? So you notice here in the common femoral, you have upstroke and you have the downstroke, and you can kind of see the dichrotic notch here, but this would represent a normal waveform. You notice that this changes as you go more distal into the leg. So what does that really represent? Is it poststenotic dilatation of the vessels due to an SFA lesion? Is it significant distal disease causing a backing up of flow and volume? Is it a normal finding, or is it a pressure cuff that is not inflated enough? So think about that for a bit. From test taking purposes, think about the ones that are obviously wrong. And for those who you know, this is actually a normal finding. Okay, so it's very important to know these normal findings. So why is it that you have essentially more volume at the below knee segment? And that is because there's additional volume of flow due to the region from the profunda and collaterals. Okay, so this is a normal finding. And that's important to know because sometimes a lack of a normal finding should tip you off. So now for some more questions. Based on the PVR, where is the most likely location of disease on the left extremity? All right, so look at it closely. Is it an aortoiliac lesion? Is it a femoral popliteal lesion? Is it a femoral popliteal and tibial lesion? Or is it just a tibial lesion? Now look at this carefully. Most people will notice there's a change in amplitude at the level here. And so if you pick femoral popliteal, you're absolutely correct. Now, you'll notice that you lost the dicrotic notch. Okay. Again, what does the dicrotic notch represent? It represents increased peripheral vascular resistance. So if you lose it, you have decreased peripheral vascular resistance. And as you guys know, with any lesions, you're going to get a decreased peripheral vascular resistance to compensate for that stenosis or lesion. And so this is how this is represented on a pulse volume recording. Let's go through another question. All right, based on this PVR, where is the most likely location of disease on the left lower extremity? So look at this carefully. Is it an aortoiliac lesion? Is it a femoral popliteal lesion? Is it a femoral popliteal tibial lesion or a tibial lesion? This goes back to things we talked about. And for those people that pick femoral popliteal, you're correct. So you'll say, Dr. Shukla, those waveforms look very normal, but remember what we discussed. It is a normal finding to have an elevated amplitude at the below knee segment. So the lack of it, again, it represents lack of volume in that segment, represents a stenosis potentially proximally, which would be in the femoral popliteal segment. Now, if you were astute and looked at some of the other information, you'll see that there is a change in the ABI as you go further down. Now, common things being common, ABI is fairly normal on the right, mildly diminished on the left. The most common lesion for lower extremity atherosclerotic disease is the distal SFA, and therefore you know that more than likely than not, this is probably going to be a femoral popliteal lesion. So remember to look at these other clinical clues that may be present on these studies. Let's go through some more. Based on the PVR, what is the most likely location of disease on the left lower extremity? Now look at this carefully. Is it an iliac lesion on the left? Is it a femoral popliteal lesion on the left? Is it a multi-level femoral popliteal tibial lesion, or is it aortoiliac disease? Okay, so for those of you who said iliac, you are correct. And let's just backtrack a little bit. Why couldn't it be an aortoiliac lesion? If it was an aortoiliac lesion, you may notice that you would not have necessarily a normal PVR on the right side. Okay, so that's why we exclude D. What about a femoral popliteal lesion? Well, let's look through it as we move down. The waveform at the high thigh looks very, very similar as we go down the entire length of the leg, likely excluding the femoral popliteal or femoral popliteal and tibial lesions. Okay, so the most likely location of it is the iliac. Is it an occlusion or stenosis? Can you tell from this study? And the answer is no, you cannot differentiate between occlusion and stenosis from this physiological study. And you have to remember these are just changes in volume. So you'll say, well, Dr. Shukla, if it's a total occlusion, you should be getting less volume. Isn't that correct? Well, if the legs hasn't fell off, you know there's going to be collateral still supplying that volume, and therefore you're not really able to tell if it's a stenosis or an occlusion. All right, more questions now. We're switching gears again a little bit, so look carefully at the waveform. We're not looking at PVRs anymore. So you have a 67-year-old male who complains of classic right leg calf claudication, okay? And his non-invasive testing as seen on the left. What is the next best test to identify an arterial etiology? So what does that look like to you on his right leg? Is that a normal ABI? Is that normal waveforms? Looks pretty normal to me. So what do you think would help you figure out if it's truly from an arterial etiology? Is it an angiogram? Is it TCP-O2? Is it a post-exercise ankle brachial index? Or is it a segmental PVRs? For those of you who said post-exercise ABI, excellent, excellent. And let's talk about that, because this is a great test to help figure out these lesions. So again, the heading is right there, and I'm gonna ask one more question here. Okay, so which represents the best exercise finding? And it popped up for us, but it would really be D. So what is the normal response to exercise exercise testing? So in a normal individual, you will get ankle brachial index on the left, and this is time. Because of the increased blood pressure, you should get an increase in the ABI, and then as you rest, it'll return back again to normal. In someone that has a flow restrictive lesion, you'll have to remember that the brachial pressure will increase, but the ankle pressure will not. So the numerator will either decrease or stay the same, usually decreases, and the brachial pressure will go up. And what will that do to that ratio? It'll drop it down. And then with rest, you will get recovery. Okay? So this would be the ideal answer. And it usually returns back to baseline in about 2 minutes. But what if it takes longer to return to baseline? What does that tell you about that extremity or the lesion? And this one's a tough one. It usually represents multi-level disease, that not only is there one potentially fixed lesion, but there might be significant multi-level disease, which will cause a decrease in you coming back to baseline. Now, let's go on to some more cases. You have a 71-year-old male with hypertension, hyperlipidemia, who presents with a non-healing left great toe. What level is his disease? Okay, is it an iliac lesion? Is it a femoral popliteal lesion? Is it tibial? Or is it a combination of fem-pop and tibial disease? Look at this waveforms carefully. What is normal? What's abnormal? How does the amplitude change? And it's on his left side. Okay. And the answer? It's a tibial lesion. So how do we figure that out? So look very carefully. You notice that there is a difference in the amplitudes of the popliteal on the left and right. So you may say, well, Dr. Shugo, it's probably at that lesion, right? Well, the waveform is very, very normal, okay, which can be surprising, but very normal triphasic waveform. So until that point, there's still increased elevated peripheral vascular resistance, which gives you the triphasicity. And you notice that as you move into the tibials, you lose that triphasicity, becomes a biphasic waveform, again representing a sharp upstroke, likely minimal inflow disease, which makes sense. And then you have decreased peripheral vascular resistance, which leads to the decreased deceleration and lack of reversal of flow. Okay? And to prove it to you on this gentleman, you look at the angiogram, you see the popliteal artery, you see the perineal, you see the PT on the left leg, and as you go down, you do see that the post-tibial artery really is occluded pretty significantly at the level of the ankle. Okay, 72-year-old male with hypertension, diabetes, smoker who presents with a non-healing second toe. What does this elevated ABI most likely represent? Okay, so he clearly has symptomatology, and his toe pressure is pretty low. It's 21. And so, but why are his ABIs non-compressible, and why do the waveforms look so bad? What could that represent? And this one's really a gimme for most of the people that have been doing this for a couple of years, and this really represents medial calcinosis. The vessels become so hard that conventional blood pressure cuffs cannot compress the vessels down, and so therefore, if the ankle pressure is infinity and the brachial pressure is 100, you're going to get a non-compressible vessel. Okay, that number doesn't have an answer. And the giveaway here again is diabetes, and as you all know, the patients with end-stage renal disease or chronic kidney disease also have medial calcinosis. Okay, very clinical scenario. 64-year-old male with hypertension, hyperlipidemia, chain smoker, who presented for his follow-up. Now he's had a left iliac stent, a left to right femoral bypass, and a left fem posterior tibial bypass. Okay, and this is a routine scan from surveillance. And just to show some examples of waveforms, okay, keep this in the back of your mind. This is what his waveforms looked before the surgery and after the surgery, okay? Though it's a very distal waveform, you do see that after even the left to right femoral bypass, you notice a significant increase and changes in waveform. Again, the lower amplitude, increased time to peak, all points to an inflow lesion, which again was fixed with the femoral bypass. But this is a great example how it's really fun and interesting to look at how these waveforms change, especially before and after revascularization. Do they make sense? Is there a reason that he's still representing, doesn't have true reversal of flow here? And it's not uncommon after these patients with critical limb ischemia, once they get revascularized, the arteries in the legs have had to compensatorily stay vasodilated for so long that they can represent a hyperemic waveform, because it takes them a while to learn that, hey, we don't need all this blood flow, and then constrict back down. And which is what's so beautiful about vascular surgery, because you know that after revascularization for critical limb ischemia, these patients get a lot of edema, and especially if they keep their legs in a dependent position, you're going to have to offer them compression stockings, wrapping, or elevation. But this is beautiful, and it all makes sense, and these waveforms show that concept. So as we move forward with that patient we described, okay, so still the same guy, left inflow stent, left to right femoral bypass, and a left femoral PT bypass, okay? This patient, this is the surveillance scan, and he comes in afterwards with this, but asymptomatic. So let's look carefully at these studies, okay? And this is exciting. So you notice after revascularization, look at the toe pressure. And the TBI, it's 0.66. Notice how it's changed. It's only 0.22, okay? And more importantly, look at these waveforms. Isn't that interesting? So after a while, the waveform which I showed last time because of the hyperemia actually switched to a triphasic waveform as that compensatory vasodilatation went back down because it's had blood flow for a while. It's such a beautiful thing. So look on the left side here. Where is that lesion we're looking for? Is it a problem with the left iliac stent? Is it a problem with the left to right femoral bypass? Is it potentially a problem with the left femoral PT bypass? Or do we need to actually look for a new lesion? Is there something else going on here? So before, after, and what are we going to look at? So let's go through it. The answer is we're looking at the femoral PT bypass, but why not the other things? So if it was a left iliac stent or a femoral bypass, well, what else would be affected? The right side. That's 100% right, guys. You guys are on top of it. So you would see a change in the waveform, which may represent inflow stenosis like we went over before. So if his femoral to PT bypass is down, occluded, or if there's a stenosis at either end or within the bypass, you will get significant decrease in perfusion, which we see from absolute decrease in the TBI. And you also notice that there's a huge change in the waveforms, okay? There's a loss of amplitude, okay? You notice that there is maybe a little bit, not really, but there's definitely seems to be a little bit more normal-ish looking waveforms. Here, the lack of amplitude really tells you all there is to know. And in fact, this patient did have a lesion at his distal anastomosis. So again, great clinical corollary. And guys, with that, that is the end. I hope you have enjoyed coming back with the clean scalpel. I'm going to make this an ultrasound series. We're going to go over different waveform patterns that are commonly recognized in the venous phase, also sometimes in the mesenteric, and always one of my favorites is the cerebrovascular circulation. So that's to come in the future. It's great to be back. And again, if you have any questions or concerns, please write them in the comments below. I will get back to them as soon as possible. But I think this will help most early medical students, residents, and hopefully it'll be a good refresher for some of the senior residents or people that are now taking their RPVI. And with that, we'll see you guys next week.